Well, first of all, thank you very much for the invitation. It's really an honor to be here, thanks to the Dutch group of parents with LFQ patients. I got in contact with your very well-organized network. Well done. Okay. My name is Elise Huisman, which is a terrible name for foreign languages. So most people will say Hausmann, which is very familiar for the German people here. Okay? I work as a paediatric haematologist in the Erasmus Medical Center in Rotterdam. So I am a colleague of Virgil Daum. And this is also my very first disclaimer, because I will present a few data from the research that we performed thanks to all the patients in the Dutch network. But a part of it is about the neutrophilic granulocyte, which is very immunological. So I will tell you what I know. But it's not my expertise, so I already asked Dr. Paris to step in with difficult questions. Also. Okay. For my presentation, I might tell you something you all already know, but I want to make sure that if I tell about the results of the research that we did, that you all realize that one of the patients that is included is not exactly similar to the other patients that are included. For me, it took a while to understand that with Jacobsen syndrome, basically they mean only when the terminal part of the 11th chromosome is deleted. So if we look to the final part of this figure is the final part of the chromosome, the long part of chromosome 11. Normally you have two copies. When the terminal part is missing, we call it Jacobsen syndrome. But in the cohort of patients, there are also patients that miss a middle part of this chromosome. Or patients that have an extra part of chromosome 11. I'll come back to that a little bit later. So tonight I'm going to tell you about two specific blood cells. It's the platelet, of course, because I am a pediatric hematologist. And it's the neutrophilic granulocyte. And I tell you why our interest is in these two blood cells tonight. You know better than I that patients with LFQ disorders may suffer more frequent infections and more severe infections. You all know better than I do that the antibodies are well known to be a part of this problem because they can decrease or not function very properly. And you may all know better than me probably that there is an increased bleeding tendency possible in the patients with LFQ disorders. And there comes our interest, because what we know in the platelets is that if they look with very specific microscopy techniques, that certain granulae are too large or look abnormal. And a granulae, you have to think about what it is. It's like a little bag that is completely full with important goodies. It's like little TNT bombs. So when there is a bleeding or a trauma or a surgical incision, we need to fix that and make a proper clot. You have many factors in your blood that make proper clots, but platelets are your first aid in clotting problems. They're there. So when there is a problem, they do a typical shape change and become activated. And then they just throw their bombs. And by doing so, new clotting factors that normally needs to be activated first are already on this very first step in the bleeding control. And they activate other platelets, so it becomes like a tsunami. And the funny thing is that neutrophilic granulocytes have granulase as well. So therefore we were wondering if there is a more infectious burden in this group of patients. Maybe these neutrophil granulocytes that also play an important role in our immune system might have a dysfunction as well in their granulase. To show that they are really close together, they're like cousins a little bit. I talk you through this figure. So all our blood cells come from the same basic mother of cells. And very early there is a division. And at the right you see all these lymphocytes, the natural killer cells, that I'm sure that other doctors have been talking about. But if you go to the left part, all other important blood cells are made in the left part. So completely to the left is fat boy, is the megakaryocyte, and he makes platelets, thrombocytes. And then slightly in the middle you see the neutrophil. Now you know they're cousins. I explained it already a little bit, but here you can see at the left side how these neutrophilic granulocytes look alike if you look at them. So when you see the circle in the middle, there is this large purple nucleus. And around it there are all purple dots. Those are the granules. You can see the little bags. Platelets are much smaller, so I only took a figure. But there you see the most important granulase from the platelets that we know now are the alpha and the denser granulase. They're really called delta or dense. Can't help it. What we also thought about is that we know other clinical syndromes that cause a functional defect in the granulase of both platelets and granulocytes. The first one is the Hermansky-Putlag syndrome, type 2. Because there are more subtypes, but it's especially the type 2 that makes you vulnerable. And it gives this very typical albinism, meaning that there is no color in the hair and the skin. And very recent there was a publication about the gray platelet syndrome. So there you see, for example, this is a microscopy to show how small the platelets are. These are the small purple dots in between the red blood cells. And I heard a translation say violet, which is better, because violet, in my opinion, is slightly more pinkish, because it means they are too empty, too gray. And that also means because they have too little working, functional granules. And these authors show that also the neutrophilic granulocyte of patients with gray platelet syndrome are less well developed. So this is to show you the variety. I'm not going into in detail of all the patients that helped in this study. And it's important to show that 2 have an interstitial deletion, which are 11 and 12. And 2 patients have this extra copy, 13 and 14. We did include this variable cohort because if we ask about immunological symptoms and the bleeding symptoms, they show the same problems. So, first of all, what I'm not going to explain every word in here. I just want to highlight a few symptoms. What we learned from this medical history that all these parents were so willing to give is that if we focus first on the group, we split the group on the patients that were already on immunoglobulin replacement therapy and the group that is not on the immunoglobulin therapy. What we notice is that in the viral infections we heard more often than expected that the varicella infection, waterpokken in Dutch, was in a lot of the patients quite severe. Leading to antibiotics topically or orally. Varicella in general in the Netherlands we do not vaccinate against because it's such a pediatric disease. And we hardly see any problems with it. So we thought that was remarkable and important to notice. Also, what we heard from quite a few parents is that fungal skin infections were reported more often than expected. It could be in the diaper area or in the nails. And we heard that a few of them had very chronic and persistent warts. And if I looked at the symptoms in the group that was not on immunoglobulin replacement therapy, we also hear these three complaints more often than to be expected for the general population. These symptoms are not really connected to the neutrophilic granulocyte function. That is important to realize. Though fungal infections might be more often seen in patients with dysfunction in the granulocytes. I skip all the... Okay, so if we look to the blood test of the patients, first of all, if we look to things we already know that the B-cell lymphocytes are often less functional. Wait. One more. Only 2 of the patients had a total white blood cell number that was too low. So that is the first column. It's called leuco, which is white blood cell. And the interest in this neutrophilic granulocyte, which is the second column, the values have to be above 1.5, so they're all good. So if you do a simple blood count in patients with LFQ disorder, you will hardly find any abnormalities. So it's important that some immunologists will test further and count and test for the B cell count, T cell count. And do the functional test by measuring the antibody levels. The vaccination response, I know that Dr. Paris talked about. So, do not always look to the figure, look to the function. So we've tested the granulocyte function in the patients. They're not a full 14 because some of them were too little to take this volume of blood needed for the test. So this granulocyte protects us mainly against bacteria and fungus. And it normally swims in our bloodstream, just watching. But when there is an infection, certain substances are made. He gets activated, and then he rolls in the vascular, in the vessel up to the endothelial parts. And then he's a very smart guy because he can get out of the vessel into our tissues, swims to the infection, eats bacteria, and produces more substances thanks to our TNT little granulase. In order to activate more immune cells to help and fight the infection. So these steps are measured in the functional test. And then you can see that in 2 patients, the first column has an abnormality in the response, and in 2 patients in the last column. But often when you see a real functional defect in the neutrophilic function, more like 2 or even 3 of these columns are abnormal. So we do not dare to say that it is really, really abnormal. Yeah. Okay, let's go back to the platelets because they are cousins. 3 years ago, Simona was here and she already presented a few of these data, and it's important to tell that also here there is number and function. So at the time of the inclusion, 6 of 14 patients had a too low platelet count. But if you compared it to the platelet count when they were just born, it was already better, or even good. And that's what we know. If you simply have more bones because you're tall, you can produce more platelets. What we did see, though, it's not on this list, but if we look to the fraction of very young platelets, 11 of 14 of these patients had a too high percentage of very young platelets. And that is a sign that even if the final number is normal, the bone marrow still needs to work a bit harder. And the same thing we see if we measure the growth factor that stimulates these very large megakaryocytes. You remember the purple ones? It's elevated in a large proportion of the group. So they need to work slightly harder, but most often to get a good output. I did not put a functional test because it's a difficult one to explain. But for almost all of the patients, the function test was clearly abnormal. So I think that is important. Don't only measure the number. Measure the function. Okay? And that is also if it is a bit more difficult to produce enough platelets and they do function, but not for the full 100%. You often have in daily life no problems. But coagulation is not a static thing. For me standing here, I have enough on 10 platelets, as long as they function. But if I'm hit by a car, I might need a bit more. Same as I have a surgery with. And for the female, we have a monthly challenge to deal with. And exactly that is what we see if we ask the patients with the various LQ disorders. With mild trauma only, we see easy bruising with sometimes large black hematomas. There can be heavy menstrual bleedings. And during surgery, if there is not a preparation in advance, we see longer bleeding periods. You can measure that with a validated score, which is the first one left top, ISTH-BAT, it's called. And for example, here you see that I've colored it red, which means it is increased. The younger children often still have a normal bleeding score. And that fits with the fact that in general, we don't bleed that easily if you have just enough platelets that work just enough for daily life. But if more coagulation challenges occur during life, we hear that it sometimes can give bleeding complications. So the same, I think, for the immunological part, that the other doctors, I'm sure, have explained that you need to test over time. It is important to realize that with bleeding complications, they can occur later in time. So what we basically advise our patients to have a proper screening on number and function. And if you know in advance that there is a large surgery coming, ask your doctor if anything needs to be done to help your coagulation. And not all the women have heavy menstrual bleeding, but if it occurs, discuss it with your physician or a gynecologist for the medication. So what medication do we have? So what we sometimes see that if you bleed more easily, you run out of your iron easily. So this is an easy check your physician can do, and he or she can supplement it. Then we work with tranexaminic acid. It's an easy medication, readily available but on prescription. But when started, you need to take it for a minimum of 5 days, preferably 7 days. And that's due to the way it works. I'll explain it to you. So coagulation, I already said, is a multifactorial thing. You have the platelets, von Willebrand factor, which is the glue. Many coagulation factors which have numbers. And whatever it takes, you need to make a strong final clot, and then like fibrinogen comes over it like duct tape. Then you're finished. But when the wound is neatly healed, the clot can be resolved. We don't need it any longer. Nor do we want a spontaneous clot somewhere to occur in our veins. So next to the coagulation there is this control system. Okay. In all patients, whatever the causes in all these factors that I named, if your bleeding capacity is lower, you hope that this set of cleaner proteins understands that and gets lower at a lower activity as well. But that's not the case. So when you have a bleeding disorder, it takes you more time to make a clot. And in the meantime, your clot is eaten with these guards. So what we do with tranexaminic acid is not helping the bleeding part, it's inhibiting the cleaners. Because one thing is important to remember, whatever you remember, remember this coagulation is all about balance. So as soon we put you back in balance, your bleeding tendency goes down. Even when the total balance is lower than what we should expect. So now you know why you have to take it for a week and not a single tablet. Because it takes a few days for the wound to heal. So what else can we do? We can use, it's either called GDAVP or desmopressin in your country. It's the same. It can be given nasally, subcutaneously, or intravenously. The oral tablets that exist are not strong enough. And when you give that, you give a temporary boost to your own coagulation. You double or triple your von Willebrand and factor VIII factor with some very strong coagulation factors. So before minor or moderate surgery, you can ask your physician to give that like an hour in advance. And usually it doesn't last longer than 24 hours. And of course, with serious life-threatening bleedings or with large surgery, and you do have a problem in your platelets, you can transfuse platelets. And then for the heavy menstrual bleeding, start with the tranexaminic acid. Give it for the full week that the bleeding is there. If that is not strong enough, you need to talk with your gynecologist. One extra thing I'd like to show you, it's good news and not good news. I am pretty sure that you know a little bit about the genes that have our interest in the ALF-Q deletion group. So especially the fly-1, I'm sure that I see someone nodding, you've heard about. Okay. So we were interested about that effect on the platelets as well. Especially because the 2 patients with the interstitial deletion have a strongly increased bleeding tendency and are on immunoglobulin replacement therapy, just like the classic Jacobson. So we also made these very specific images of the platelets. So if we start with the first one on the left, that's a healthy platelet. And why you have to look at is, can I point it? Maybe, yeah, look, I use the mouse. So if you look, let's see if there is a good one. Now, for example, if you look at these very dark ones, the dark circles, they're called mitochondria. They're like the energy battery of our cells. So here right below you see a light gray circle. That's one of these alpha granulase that we were talking about. And then there are the very, very little black dots, which are these dense or delta granulae. So in some of the Jacobson patients, we know that these alpha granules fuse, so they become very large. So this is one of the examples you see. It's the same scale, so you see that it is much larger than in the healthy platelet. But if we look to the interstitial deletion, which should have 2 copies of fly1, they're also very large. So then we compared it with one of the patients who had a congenital fly1 mutation, severe one, because the gene stopped too early. And this girl and this patient always also has a low platelet count and a bleeding disorder. And we see the same large alpha granulase. So the good news is that it fit with literature, but the bad news is that we do not really understand what is happening here. And then there is a second thing that was remarkable. There are some large structures in the classical Jacobson patients and the interstitial deletion patients and in the fly1 patient, which if you look more clear, more looks like a crystal if you have a small diamond needle or something. I'm not so familiar with these images. Someone in the laboratory makes them for me. And he explained to me that he had never seen this before. So there is more food for thought. We need to find out what it is and why it is there. And now we go back to the beginning. when we saw this, we realized that we can make the same microscopy images from these granulocytes. So we didn't do it yet, but out of curiosity we thought that might be interesting because you look so much more specific into the cell. Maybe it shows us something we do not know yet. I think that this is it. Yeah, that's it. Okay, that was my presentation. Just in time. Are there any questions? I'm not sure if this will work, but...
Thank you very much. The intranasal desmopressin, right? Is it the
crystals that we...
The intranasal med that you can get for the bleeding? Yes. Is it something that can only be used at the hospital, or is it something parents could have with them in case of emergency?
For the platelet bleeding disorder, you mean the tranexaminic acid? That's one you can put nasally.
Yes.
Yeah. No, that's made for home therapy. And it works best for bleedings that are mucosal bleedings. And mucosal bleedings are everything in our body that is slightly wet. So it's not the skin bleedings, but it's ENT, ear, nose, throat, and also gynecological bleedings. Yeah. It only well, this is a tranexaminic acid, huh? So that's what you use at home as tablets. The nasal one we could use also at home. But lately, we in the Netherlands, we cannot order it anymore. So you need to check in your country if it is available. Yeah. Because if not, then it's a subcutaneous injection, which is a medical treatment in the Netherlands. You, as a parent, need to be skilled for that. No. Does that answer your question properly?
We actually do have the in German it's called Cyclocapron.
Yeah.
So it's tranexamic acid.
Tranexaminic acid.
As an emergency pack. And we have got not the tablets to swallow, but the subcutaneous fluid.
The IV fluid?
No, it's not that. We're called, I can show it to you later.
Yeah.
And we're supposed to give that to the emergency doctor when he arrives, if something happens.
Can I respond? For the Dutch parents, we also have cyclocapron, but it is not refunded by the assurance anymore, and you need to pay a lot of money. So that's why I use the generic name, tranexaminic acid. Tranexamic acid.
And for the previous surgeries that Charlotte had, our haematologist recommended Novo 7, the factor 7 preparat. Have you ever heard of that, and what's your opinion on that?
Yeah. It's a very strong medication, so we only use it in the life-threatening bleeds. It's also very expensive, so I don't think all hospitals, it will not be available in all hospitals or all countries. And for platelet disorders, it's only approved and only studied for one specific platelet disorder, which is really a different disorder. So I think it's good to do, but usually we do not need it in the Netherlands if we use the other agents that that make more use of your own extra coagulation power, with the tranexamic acid and the DDAVP. Yeah, that's what we prefer. But it's not wrong.
Thank you.
Yeah.
After thrombocyte transfusion, have you ever seen a patient where the platelets stayed normal, or after what time it decreased again?
Oh, good question. So usually for like normal general surgery, 1 unit would be enough. But if it would be a large surgery, we advise to give a double unit transfusion, so to give 2 packages. And the platelets work while you infuse them. I mean, you have a very quick response in your coagulation support. But they are from a donor, so indeed you will lose the effect. I do not know of terms that are given to the effect of platelet transfusions. But platelets in general last for about 7 days. So I think if you transfuse them and you have an ongoing bleed or a rebleed, I would give another transfusion. Because if you transfuse during surgery and platelet counts decreases back to the normal value again, but there is no bleeding, a post-surgical bleeding, you may not treat it, I think. I would just look at the child. Yeah. And we always add this tranexamic acid to give the long serve. When the clot is made, you want to keep it strong. And the only thing from the transfusional part, I advise all of you is when there is a transfusion reaction, like fever or allergic reaction on platelets, then ask your physician to check on the platelet count during that reaction. Because it is very, very rare, but one can make antibodies against platelet transfusions. And your physician needs to know that because he can choose another platelet transfusion type.
And The other question is the opposite. Have you ever seen a patient who had very, very low platelets?
In the
That after the transfusion, everything was normal for long term.
What is long term?
Years.
With the LFQ disorder? I would doubt the pre-transfusion test count, to be honest.
Yeah.
That would be the
That's
first
what I
thing to
think
check.
as well.
But if it's a repetitive measurement, it doesn't sound logical to sudden normalize after the platelet transfusion. No. Do I need to? Oh.
I'm going to read it out. It's from the chat. Should a child having any surgery should have a platelet transfusion?
Well, I think first you need to screen if there is a low platelet count and if there is a platelet dysfunction. Because it's not in all patients abnormal. Then if it is the case you have too little or not well functioning platelets, it depends on the surgery. For example, if there's one of these little baby teeth need to be get out, how do you say that? Proper English? Taken out. Maybe I do nothing, because you can see if there is a bleeding complication and then give treatment. But if they need to take out these very large molars and dig into it with surgery, I would give something in advance. And then still we prefer to boost the own coagulation first, again with tranexamic acid and the DDAVP. But that will not be enough for large abdominal surgery, cardiac surgery.
Thank you.
I have two questions. For the meds that are to be given in advance, I understood something that it should be good to start 5 to 7 days prior to the surgery. Did I get it right? Oh.
We only start if we know that the surgery is scheduled 1 day before surgery.
Okay.
With the tranexamic acid. But if it's an acute surgery, you start at the moment of the surgery. And then you can give an IV bolus.
Okay. Our daughter had lead surgery, so it's not big surgery. And she had the med,
Tranexamic acid?
Yeah, I know the name of the French brand, but 2 days prior to the surgery, but it was not enough. And it bleeded a lot.
Yeah.
What could have been done, because then the surgeon could not finish properly?
I understand.
Mm.
I think when the complication of bleeding is there, you need to give a platelet transfusion.
Before. Yeah, okay.
Or a
because
second one.
Because you know it's going to happen.
Yeah.
Yeah, okay.
And at the moment, and for a new surgery, especially the thin skins often bleed heavily.
Okay.
And some of the children are born with this craniosynostosis, can be a part of LFQ. That's a surgery that gives a very heavy bleeding.
Mm.
You never the DDAVP or tranexamic acid will never be enough for that. So it really depends on the surgery, and I think your physician needs to balance on that one.
Okay, thanks.
Yeah.
I have another question. I saw the iron supplementation on your list, and I was wondering, does the patient need iron because of the iron is losing because of the bleeding, or is iron helping with all the clotting thing?
The first answer is you lack iron due to an increased bleeding tendency and the lack of proper oral dietary iron intake. Which is very normal for all infants, toddlers and young school-age children. And only when you have a very severe shortage of iron, it results in anemia, and a very severe anemia negatively affects your platelet function because the platelets move to the middle of the veins. But if it is that severe, I hope your child is in medical care. And then the best thing to give is a red blood cell transfusion, because and you solve the anemia, and there is a lot of free iron in the red blood cell transfusion. So
It's better to have a check to prevent anemia.
no, I do assume that most of you visit some physician on a regular basis. So if you think that your child is really pale or it eats really badly, or it does bleed more heavily than others, I would check on it, because you can do it with the 2 drops from the finger.
Besides the iron supplement, what do you think about giving vitamin K supplements to help the children? Because we just tried it out with our daughter, and it really helped, but we can't say anything about other children. But what are your thoughts about that?
So that's a good question about vitamin K. To answer the question, shall I explain how it works on the coagulation first? So we have platelets, and von Willebrand factor, this glue thing, which gives the very first aid in a bleeding episode. And then all these coagulation factors get activated, and they make the real strong clot. 4 of these rely on enough vitamin K to be well produced. Normally, if you have a normal variable dinner or meal, you should have enough intake of vitamin K. When you're breastfed, it's not enough. So babies should have extra. And when you have a child that eats very, 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 very miserable, you can get a shortage of vitamin K, and maybe it's then the add-on effect that if the platelets are not working well, and then you're low in your helpers that rely on vitamin K, I can imagine it gives more bleedings. I would not give it blindly. Because when you are too low, one specific coagulation test prolongs, so you can measure it. And that's called the INR test. PT or INR is the same. So I would discuss it with your physician if you think that your child eats badly, and then test for it. Does that answer your question?
Yep.
No more questions.
Any more questions? Any questions from the ones on the internet? Then, thanks a lot.
Well done. Thank you for listening.